back on. So we'll kick off again if that's okay. Nice to have you back with us. Okay, so as part 2 of the session, I'm going to look a little bit more about how to make sense of health data and information. So in that first section, we've explored how we might search for data and how data is constructed. Now we're looking at how we might make sense of that. So of course, research is influenced by a number of frameworks, the philosophical, the theoretical, and the ethical. So the first decision that one might need to make about research is how we understand the world, how the world should be studied. And we started to get into a few discussions in that first block on qualitative and quantitative data. And so a key decision here will be whether you think the topic that you wish to study can be followed and assessed through numbers, or whether we need a bit more depth and we need to learn about people's experiences through words. Then you might reflect on your theoretical framework. And many people will take different theoretical frameworks, and that's the weird and wonderful exciting thing about research, is that there are many different lenses that we might adopt when we wish to take on research. And then finally, ethics, which of course is vitally important in so many fields, but not more so in health and well-being. Thinking about the dignity, rights, safety of those being researched, and of course the researcher. So generally, as we discussed previously, research strategies can be quantitative, qualitative, or mixed methods. And I'm sure many of you will have previously explored the value of taking a mixed methods approach, drawing in some statistics, but then also looking at exploring people's experiences, their attitudes, their feelings. But as I'm sure you're also aware, there seems to be an established hierarchy of evidence. Does anyone have general experiences of a hierarchy of evidence and the challenges that may bring? I can see a hand from Fiona.
That was on mute, sorry, apologies. Yes, again. Yeah, just internally, where if you have an idea, you're hearing themes and trends for people, but there's actually a process to get through to perhaps our partnership team, who are often very medically based in their experiences, is to how you get that narrative over to them about what you're trying to do, you know, almost like you have to prove that's why you're doing this, because we've seen this, that, and the other. You know, we've had some qualitative stuff. So it's the language that we use often to get the message across. It's that really strange hierarchy that they're exactly the same as we are, but there's this perception, because they've often been nurses, that they're somehow better. That because I've got the University of Life PhD doctorate stuff, you know, my evidence, giving them my evidence in the simple language that I would use talking with anybody, is nowhere near as valuable as somebody who comes back with what I call big sentences, big words, and speaking in riddles.
So again, there's this ideological bias towards anything slightly clinical.
Yeah.
Okay. Jenny Ann?
Yes, I think there are several points here that a colleague has just raised. One is about the language used can be really either inclusive or exclusive in terms of getting good evidence and of explaining it properly. And I think also there is a difficulty that sometimes if you're looking at a particular area, there are people who act as spokespeople and who funnel community interaction into a survey, and that may be biased. That you may think, oh, I'm not going to ask those people because they're not really very good at this stuff. But actually, they've got something quite useful to add, even if it's just we're not very good and don't understand this. And there is also the thing that goes on, I think, everywhere is consulting the usual suspects, which is where you always go to the same people because they're the ones who are prepared to engage. Mm-hmm. And it's very hard to get past that to engage the parts of the communities that don't normally engage. And I don't have a good solution to that. I don't know whether you do. For instance, we always get consulted about trans populations because generally we'll answer. But it shouldn't be just about our opinion.
Yeah.
Just going to add a little bit onto that, Chris. And
great.
Just at several charities, when you sort of want to set up a patient advisory group or a forum, again, it's quite easy to fall into that. It's the same suspects, like Jenny was saying. Sometimes have a rigorous interview procedure with 2 trustees interviewing. You're automatically excluding a huge swathe of your service users, for want of a better description. So I think it's charities have got to be more mindful to try and get a more representative pool of patients and family members. And it's something I think the people in this room will always champion. But some ways we're trying to simplify language, and that seems to work this week. And then next week we've got this rigorous interview procedure for getting patients involved. So it's constantly swings around about and juggling, I think, is what we do best.
Sure, and I guess that's the big challenge, isn't it, where different partners will prioritise different forms of evidence. Okay, Karina?
Hello. Can you hear me?
Just about, yeah.
Just to say I've got to go in a minute, but I don't know if anyone's heard of an organisation called NSUN, but they're the National Survivor User Network for people who have been in mental health services, and they've got loads of amazing stuff about involvement on their website. They've created a charter and like ways of doing it really meaningfully and in a proper way. I thought that might be of interest to people.
Hi, Karina. I know you've got to go in a minute. Could you put a link to that in the chat or send me it later on and I can send it out to the group, please?
Yeah, I'll do that now, Sandra. Yeah.
Super. Thanks very much. Okay, so there's some really good discussions there on this hierarchy of evidence, but I think to unpick this further, this is a kind of general hierarchy of evidence, but then what makes what makes this even more complex is that different organizations will adopt a different hierarchy, which I think creates an even further challenge perhaps. You were also discussing target groups quite a lot there, and what I've found with my research with local government is that yes, there are only certain groups that choose to interact with local governments, and it's very often those groups who are listened to and sway opinions. But of course, there's also the factor where that group certainly doesn't reflect the majority. So I think that's quite interesting in terms of the ways in which decision making is made. It's often the 10% that are listened to who might have the strongest views, but that doesn't always mean that that's reflective of population need and population interest. Emma?
Yeah, something I was going to say was that what we've been trying to do over the last few years is where there's no local research or evidence, we look for national or international evidence, and members don't like that. They like things to be very, very local. So what we try and do with them is to say, what evidence do we have that the findings of this research are not the case in our area? And if we don't have any evidence, then let's feel comfortable using this national research. And that's been really, really helpful for us, certainly when we've been doing our wellbeing assessments and other needs assessments. And I think when you frame it like that, people can see the sense in what you're saying. Otherwise, we just have loads and loads of knowledge gaps when there is some research that we could use.
Really interesting. And how's that process gone in terms of, because again, it's something I've seen in my research, convincing members to consider research beyond their remit geographically?
I guess on the whole, it's okay. I guess it depends on the topic area and whether the research is in accordance with their worldview as well.
Yeah.
But it seems to go fine. I think as well it's worth saying that we've had to use that line with some of our senior officers as well. And I think because it's just makes such common sense, people tend to accept it. Actually, it's okay. We've not had anyone totally refuse to include, non-local sources yet, put it that way.
Sure. That's really interesting. Thanks very much.
Thank you.
So we move to the next slide, really, where we reflect on, is there a best approach? And to take the quote from McLean, it's not really a point here of having a fixed viewpoint on what is better, though as we've discussed, it seems though in practical terms, some people do have a fixed viewpoint on which is better. But it's about looking at what's the best approach for what you're wanting to find out. And I think these points related to vaccines make it really clear. So whether a coronavirus vaccine works, you would want to conduct quite different research, a research strategy to the question of people's views about vaccinations, or whether or not they're likely to come forward. But of course, very often, when funding comes into play in particular, people seem to prefer the harder sciences. So to summarise this second section, research needs to be understood in the context of philosophical, theoretical and ethical frameworks, and these will all influence the questions and the methods that you or researchers may adopt. There are three overarching strategies: qualitative, quantitative and of course mixed. And it's not a question of having a fixed viewpoint, it's about what method best suits your research question. And believe me, that's something that I have a real task trying to push through with our own students. Practitioners need to be aware of frameworks that influence research and research methodologies, so that they can identify appropriate and good quality evidence for their needs. And then, of course, it's about convincing partners of good quality evidence and what evidence is best suited to needs. Before we move on to the final section, part 3, and anything else that anyone wants to add at that stage? Okay, super. Hang on, something's flashing at me. Thanks, Karina. Thanks very much. Fiona just says using other sources from other countries as part of her engagement work does often add gravitas or weight to the work that she's doing. So that's really interesting as well. Finally, then, looking at how we might use health information and data in practice. And please do join in here, because this is something that certainly at the applied level, you'll be far more experienced than myself. But we're looking at these 3 essential ingredients: theory, a blend of theory, practice and experience, and evidence and research. Moving on to epidemiology then, where we know we'll have high relevance to health and well-being, described as the basic science of public health, the study of occurrence and distribution of health-related events, states, processes, including the study of determinants and the application of this knowledge. How would then, if we're thinking from an epidemiological basis, how would a medical doctor and public health practitioner diagnose and treat the issue of depression? What kind of process is involved?
Well, that shut us all up.
Yeah. I guess it's the same as any other piece of research. You've got to define the problem, find out what information's already available, determine what you need, and look for information or do research, then look at the results and try to put together a new strategy, look for funding and try and implement it. I mean, that's how I look at it as a scientist. But I think sometimes there is this idea that health is somehow different.
What do you mean by that?
But because it's such a human trait that it's very hard to have hard and fast rules, because everybody's biology is different. You know, you can come up with some general ideas, but it won't suit everybody.
Mm-hmm.
And I guess that's where your health professional comes in, who understands that. And we see in some of the work we do that very often health professionals will use a range of results to determine what to do, but there are lots of what I previously called outliers where their metabolism doesn't quite work that way.
Yeah, yeah.
So the other thing for that is that you could be sort of halfway through this piece of work and something like the pandemic could come along that nobody could have expected or planned for. And it could really throw a lot of that either out of the water or need to scale up or down, you know, quite drastically midway through a piece of research, I suppose. It's how could anybody have foreseen what we've been through? You know, it's
Mm-hmm.
how do you get agile in that situation?
Yeah, really interesting. So I think, Jenny Ann, you outlined that process, I think, really clearly. How we often approach health, public health, identifying issues, measuring prevalence, identifying causes, and then leading into the intervention. So I think you described that really clearly. What I think is interesting, flicking back to this previous slide, is that the blend of this process is not just the evidence research side, but also practice, experience and theory. And so something that really interests me with topics such as depression is perhaps the medicalized nature of our approaches. And, you know, I think that blend of experience, theory, many of our we are a medicalized society, some might say. We look to seek to find medical clinical solutions to an array of behaviors that prevent themselves, and I think we certainly see that within our practice. So I think that's worth reflecting on as well. It's how it's not just the research, but there's a blend of those three ingredients. And so we do, of course, we like to have a lot of evidence-based practice within research. Of course, we discussed in section 1 how when it comes to policy, the ideal is evidence-based policy, but what we might often find is more akin to policy-based evidence which suits the policy. Less so within health, you would hope, in terms of interventions. But evidence-based practice, to take this first quote, is the process of systematically reviewing and appraising using scientific evidence to underpin practice. So finding evidence, appraising that evidence, and then applying that evidence to practice. Formed through a somewhat regulated process of turning research from randomized control trials into practice-based programs. So going back to this hierarchy, does anyone see a lot of prestige placed on randomized control trials? And what might be some of the issues with the priorities placed on randomized control trials in some contexts? They cost a lot of money. Yeah, thanks, Stephen. Fiona?
Sorry.
Sorry, Jenny, we'll come back to you, Fiona. You on mute, perhaps, Fiona?
Oh, done it again. You think by now I'd have got it right. There's something about the time involved in that as well, and the recruiting for the trials and all the ethics behind all of that as well. I'm not really an academic, so this is as simple as I understand it.
No, that's really helpful. Thanks. And so we've got from Fiona Duncan, the number of people taking part might be an issue. From Joanna, there's lots of ethical barriers. For example, you might be unable to do trials with people who are pregnant. Absolutely. If you look at something like education, you can't do randomized control trials because you're dealing with children's development, in terms of learning practices and learning theory. So that might be very, very difficult. Going back to the point on depression, it may not be appropriate to assess an intervention via a randomized control trial. Would anyone like to unpick that further as to why? Jenny Ann?
Yes, it was the point I was going to make, that in a lot of cases you can't do randomized trials because you're then saying some people we're going to treat and some we're not. For instance, in a sector I know about, and you partly alluded to it, is you can't take young children and say, right, you're ill, but we're going to make you random, so you won't know whether or not you get treated, and some of you won't. And it could, in the end, impinge on their life. They may lose their life through it.
Absolutely. And I think the other big thing here is that it's very difficult to assess, I would argue, people's feeling of well-being, people's feeling of social connectedness via a randomized control trial. So there might be something where we're striving for outcomes that simply it is not appropriate to measure via a randomized control trial. And that, again, is one of the issues with the hierarchy of evidence that we find. Sorry, Julie, you're on mute there. But I was
just going to say, I just wonder if there's something in there. Well, there was a hospital, a documentary called Hospital, and it covered different hospitals around the country during COVID. And part of that at one time was a randomised trial. But I just wonder about sometimes the impact on the wider staff when they don't know what they're necessarily giving in the moment. It was a treatment. And some people might have lived through the treatment and some people might have died, and they were dealing with enough already. At that time, I just wonder, you can't really sort of allow for that, can you, on a piece of paper and a research finding?
Absolutely, yeah, really good point. And thank you to those who need to head off. But thanks very much for your contributions. From John, there needs to be clarity around the purpose of research for it to be embedded. Is it commissioned, commercial, or academic only? Really good point. So the purpose impacts on whether research can be embedded. Randomized trials also bring risk and whether the entity is prepared to hold the risk. Yeah, really good point. So we've got these points of it's not really appropriate to say some can't be treated. We've got the points of risk associated and what this evidence is for. From Stephen, RCTs are only as valuable as the clinical endpoints they are assessing. Great point. It's all about the outcomes, isn't it? What's the intended outcomes of your research, and what's the intended outcomes of your intervention? The real challenge, I guess, many will have had these thoughts, these reflections for many years, but it's about how do you convince partners, decision makers, funders to see the same viewpoint as yourselves. And going back to this previous point on, we've presented lots of case studies here on various different cases of health intervention or health assessment. We won't go into breakout rooms quite simply because I haven't got the functionality to do that. But we've been discussing things, quite openly and clearly through the group. So I really appreciate that. So if anyone wishes to pick one of those and discuss one that interests them and perhaps discusses how health information data could be used, I think that'd be great. Maybe if we take 2 minutes with our cameras off and just pick one that might incite a bit of interest in you and come back with your reflections. Would that be okay? Super. Okay, I'm back. So please feel free to join in when you're ready. Jenny Ann, great. You've got your hand up.
Yes, I'm the stooge that always goes first to get people going.
Brilliant. I've really appreciated it throughout the sessions. Thanks very much.
I'd like to talk about the one about being tasked with developing a health education resource, because we do training in all sorts of areas, particularly with the health boards and the GPs and the Welsh Gender Service, the government and so on. And we try to go about that in a systematic way. We research what it is we've been asked to do. We look for information and statistics. We also look at real life experience. We scour the net for information, and particularly we like using video resource if it's good to keep people's attention. And most importantly, we use members of that area to present the courses to people. So not only are they invested in the subject they're talking about, but they can answer questions from lived experience. Now, I'm aware that, again, doesn't represent everybody, but it represents a wider area than somebody just doing a piece of research in an area they're not familiar with.
Super, that's really helpful. Thanks very much. Anyone else wish to? Julie, great. And as a further challenge to everyone, just before we bring Julie in, I'm going to add a second question to this. How could health information data be used? And then also, how are you going to convince your stakeholders that this data and information is appropriate, worthwhile, and should be used to inform decisions? So, Julie, please don't feel that. Click on that second point.
While you've become aware of an issue through the media that might have implications, that happens all the time for most charities with a health condition. So I'm thinking about liver health particularly, and about some trials that were available that came out in the media for people if they happen to catch COVID. Now, our community have been really rigorous about shielding, doing the right thing, but obviously as things change, they've opened up. And unfortunately, some of them at that exact time, we sort of publicised the details of the trial. One of our patients locally did catch COVID, and because we'd chosen to disseminate that information, he has now become involved in that trial. He didn't realise when he signed up that was going to be for the next 10 years, but it is. But what we found is that's a really healthy two-way relationship that we have. They trust us enough that we're only disseminating things of quality, and we do explain it as well as we can. But I think there's also something there about some of the more negative stuff that you will find in the press about obesity related stuff affects our patients, and drinking, viral hepatitis, all the main risks for liver disease. And I think it's our job to either go back to either our own research, regional research or national research, to either allay people's fears if that's true, or to try and sort of dig a bit deeper if it's not, and to sort of make sure that they're fully informed and not hitting that panic button because there's been a shock headline like we were talking about earlier.
Sure. That's really helpful. Thanks very much. Anyone else wish to add anything there if I just move on towards our summary? Okay, super. Jenny Ann?
Yes, as nobody else is speaking, I was just going to say an interesting point that we often find is that you'll get people who will say, no, the statistics are completely wrong. That's not my experience. And it's a real task to keep those people included. But yes, statistics are statistics, and it's what happens on average. It predicts what will happen on average, but it doesn't predict what will happen in an individual case. And we do some work with the prison services, and there it's all about risk, but they often use the statistics to prevent things happening because there is some risk. And we argue hard that yes, there is, but you've still got to look at an individual case because it may buck the trend. And aren't you trying here to improve things, not to just make everybody who's in the criminal justice system stay criminal?
Sure. Really interesting. Thanks very much, and thanks for your contributions throughout. Just to read out Janice's point from the chat, she said that they invite both professionals working in the field and those with lived experience to training so that groups can be delivered jointly together, and that lived experience is greatly helpful in the nature of the groups that they deliver. So evaluation from training and outcome monitoring of attendance / retention of groups following the training. And I think, yeah, it seems as though that's a regular measurement in terms of retention and attendance. We certainly see that through things like X5's referral schemes and that kind of stuff. That seems to be one of the leads because, again, funders want some form of stats. And so I guess many of you will have a lot of experience of boxing clever and thinking about the different needs of different funders and different partners. And it seems as though, to take that example from Jennifer, many of you might be leaning towards more mixed methods approaches, either in the research that you collect or the research that you present, whether that's local or whether that's looking across the UK and wider. If I can just summarise then this final section, there are 3 essential ingredients for working effectively in health, mental health and well-being, and that is this blend of practice and experience. We've discussed that a lot, and how that enmeshes with theory and the evidence of research, but not just how that enmeshes with research, but there really is a link between the 3. And so your attitude to how you think the world can be studied and how you think humans can be studied will affect your theory and your evidence choices. Epidemiology has been described as the basic science of public health, which involves information and data in order to identify and also understand health challenges, who they impact, how, with a view to doing something about them. So evidence-based practice then can be understood in slightly different ways, but is essentially the process of systematically reviewing, appraising, and then finally using that evidence to underpin health practice. And so that practice becomes evidence-informed, not finding evidence that is policy-informed. To apply evidence research to practice, those working in the health sector need to collect relevant, of course, good quality information and critically consider what the findings mean for the issue, population and setting they are working. So, of course, that doesn't mean it has to be evidence from that population or setting, as many of you said, but it certainly will need applying and unpacking. So finally then, oh, Julie, you have a hand up? Is that from previous? Or?
Sorry, I didn't think my hand was up, but there was one final point about having established that new good practice. You've got to continually evaluate it and evidence that it's effective or if it needs changing. And as we've already said, something like a pandemic comes along and you've got to reevaluate it completely.
Yeah, super. That's really interesting. Yeah, and I think certainly in terms of my area of research, active travel, the pandemic changed many things, but as we start to move out of restrictions, it'll be really interesting to see in what ways we go back to old ways in terms of our transport and our thinking. Active travel was presented as something that was really great for not only being physically active, but being socially distanced on our commutes. But of course, the other choice of being socially distanced on our commutes was to take the car. So I think it'd be really interesting, yeah, not only to follow things as they went through the pandemic, but then also post-pandemic. So thanks very much. So final thank you to everyone for joining today's session. I really have appreciated your contributions. I found them so interesting and they've really helped to advance the session. I'm sure everyone else felt the same. We thought we'd include this information. Is there anything else that you'd like to interact with us further? Here's a list of the different courses that we offer, the middle 3 being our undergraduate programs. We also have a master's program running in health, mental health and wellbeing, and Sharon, who's joined us, is the program leader for that course. So we'd like to highlight that we do actually have a workshop running slightly later in this year related to compassion, burnout and well-being, and I think that will give you a really nice taster of the kind of things that you might study with us, either on the undergraduate or the masters. Sharon, the date for that has been shifted slightly.
So this is the next one we're doing for this engagement practice forum, and we also have a masterclass in public health, mental health and wellbeing, which you can find on our website.
Super. Sorry to bring you in there. Thanks very much. So that's clarified that one. That's our next workshop, and then we also have the masterclass related to our masters. If you'd like to direct any questions about the programs, the masterclasses, the workshops that we have with you, here are our emails. And yeah, thank you very much for joining in. I've really enjoyed our time together, and I hope you have too. Karen.
Hi, I just wanted to come in there to thank you and Sharon for putting all this together. It's really raised, you know, the range of discussions this morning have just been fantastic, and I look forward to replaying the recording so I can absorb it a bit better. And I'm sure we've all got lots of questions, and it's just raised quite a bit as well. And you know, looking back on how we find and filter through all this wealth of data and information that's out there, making sense of it, and sometimes always challenging it. I know we've done that with the COVID vaccination. Don't always, you know, when you are given that information or some insight, even make sure it's relevant at a local level. So we've certainly challenged some of the information coming through, and you know, and that helps you look at how best to use it in practice. But huge thanks for you know, launching these sessions, and it's a great partnership working, and huge thanks to Glyndwr for hosting it, and to Sandy for putting it all together. And as Chris said, you know, I hope everybody's found it valuable, as I'm sure they have. I certainly have. And if there are any more, I know Sandy will be in touch, looking for feedback to how you felt it went, and you know, and I know lots of you have had the opportunity today to take part, and it was great to see so much active participation. And you know, please let us know if you'd like to do something different. If the format was absolutely brilliant, I thought, but let us know if there's anything else that we could help with or do differently. Jenny Ann is coming in.
Yes, thank you, Chris. I just wanted to say that was a very interesting and thought-provoking session, and I would say a model of how to do this stuff online. And we will learn from you to do our courses better.
Well, thanks also to Sharon, who put all the resources together. I just came on and took the glory at the last moments. Yeah, thanks very much.
Thank you, Sharon, too.
Had a dental emergency this morning, so Chris kindly took over, and he's done a wonderful job. So thanks to Chris for that.
Oh, hope it's all right. Thank you ever so much, everybody. Thank you. Thank you.
Thanks, everyone. And there's the really interesting point from John just popped on the chat there. If anyone has the chance to read through that before we go, yeah. Thanks very much.
Thank you.
Right, Rafat.
What a lovely chap.
Oh, they were brilliant. I'm just going to try and stop the recording.